Hi, everyone. I hope you had a nice taco lunch. Even the food was chosen by Marissa, by the way. Thank you, Marissa. I can't believe we're in the home stretch of this conference. I'm excited because we've planned this for 2 years and really intensively the last year. This is the cherry on top because it's already been such an awesome conference. So thank you guys for all of that. And I know that there are people who've really been engaged virtually as well and have been sending so many messages. And so really, not only do we have a global presence in this room, but this meeting has a global presence. And we will absolutely be continuing these kind of conversations beyond this meeting because, we have plans and it's important to formalize them. But also we will continue to meet in this unique community that I'm really honored to be a part of, and I know everyone feels similarly. Unfortunately, the global RB panel at SIOP overlaps with the global RB panel here, and we planned ahead of SIOP, so we had already been a little bit locked in. So you will notice some people step out this afternoon. They are continuing their work at another venue, so please just understand that. And then I think we have a special presentation. Is that right, Summer? Okay, great. Come on up. Thanks, guys. Should the panel come up too, or after Summer? And the global RB panel, if you guys want to sneak in quietly behind Summer, please. Come on in, lady.
Good afternoon, everyone. Good afternoon, y'all. Look, I don't know about y'all, but I'm excited. This week has been absolutely amazing, and I just want to take an opportunity and clap once again for Marissa and her awesome team. Come on, I know we just ate, but we can make some noise. Give it up for Marissa again. Yes, thank you. Oh, wait, we have someone else.
So much energy. You out-energy me, and that's saying something. New board member. Woo!
Thank you. Yes. Yeah, thank you so much for that as well. So yes, I am the newest board member, and so I'm looking forward to working with We See Hope. So I just wanted to take a few moments of your time. You guys got an opportunity to meet me during the parent panel earlier this week. For those of you who didn't, my name is Summer Stanley, and I have a 7-year-old thriver who is currently downstairs in the Child Life program. And I want to just recognize the impact of representation that has been here for me today. It has really been inspiring and enriching for me to see so many adult survivors and to learn about your various career fields and things that you're doing in your community, because that confirms for me what I already believe is that my daughter is going to be amazing, and I don't have to pity her and I don't have to do everything for her. She's going to be great. And thank you to Grace right back here. Yes, Grace. Thank you to Destiny. I don't know where Destiny went, but thank you so much to the two of you, because just talking to you guys today at lunch, it made me emotional. But that level of my daughter being able to see adults who look like her, who are doing things like becoming a neurosurgeon, is that what it is? Am I saying neuroscientist? Neuroscientist is just, yes, yeah. And so just thank you all for that. But I would be doing a disservice to my lifelong work if I didn't take a moment to speak a little bit about what I do. Everyone here today has shared, this week have shared their unique specialties and areas of expertise. And I have been working in inclusion and accessibility for about 15 years now. My work centers around improving information access for deaf and hard of hearing individuals and individuals with visual impairment. Specifically, my organization focuses on medical information because we know that these community members, they don't have the same access that we have. They don't have the opportunity to sit at the table with family members and learn about their history. They don't have the same options to scroll social media and a video pops up where someone's speaking and talking about the glow in their child's eye. They don't have access to that. So when we speak about these marginalized communities as a whole, the cancer impact that happens in that community has a lot to do with late detection and lack of awareness. So I wanted to share a little bit of information with you all about the work that my organization does and how you all can change that. And I'm charging you with this. Most rooms that I step in, I go in having to fight through the door for the executives in that room to understand why they need this in their hospital. But you already understand the importance of awareness. About 6 or 7 months ago, we launched Inclusive Scan. Inclusive Scan is a 3-format QR code that you can place on any medical document. And what it allows this community to do is you scan that QR code, and up pops an interpreter who is putting that information in ASL for those deaf and hard of hearing community members. It also has a voiceover for those with visual impairments. So that includes those who may have Usher syndrome, cataracts, glaucoma, or, like most of us, just aging population vision loss. The need for this is more than just necessary. It is a requirement. And more medical institutions have to take notice that this group, although it seems very small, there are 37 million people in the United States alone who suffer from some form of hearing loss. There are over 12 million adults with some degree of vision loss. So when we fail to think about those communities, we lack the opportunity to give information access to those individuals so that they can be proactive in their children's health and in their health. Does that make sense? All right. I was not going to speak today, so if this is not hitting home because I don't have any visuals or anything, follow up with me later. All right, there we go. So despite these challenges in that community, medical treatment disparities are still very common. The limited awareness and accessibility within the healthcare system has caused individuals to come to us and tell us that my family member died because their doctor, who spent 15 minutes with them in this setting, said, hey, you have diabetes, and gave them pamphlets to read over, right? Well, American Sign Language is a completely different language with its own syntax, its own grammar structure. It's no different than someone who speaks French trying to read English, or you yourself going to another country and trying to read information that's provided to you, unless you're fluent in that language. So this is not just a one-off problem. We see it often. With that family, the father was taking his medication all the time where he was only supposed to take it if his levels were at a certain number. He didn't know that. Why? Because that information was in his pamphlet. We have people who come to us who talk to us about being stage 4 breast cancer, and they didn't know that it could be hereditary. So they didn't know to ask their parents about their breast cancer history and to know that they required more frequent checkups. So when we talk about retinoblastoma, I really want to create that awareness for these communities that I support. We can do this in a number of ways, but Inclusive Scan has proven to be one of the most cost-effective and sustainable ways to provide that information. This does not take away the need for interpreters in these spaces. So if you're familiar with American Sign Language interpreters under the ADA, Americans with Disability Act, it does not take away from the interpreters. It's simply an addition, so that once that interpreter interprets exactly what the doctor says and those pamphlets are handed, well, now that deaf person or that person with that visual impairment can scan it and actually get information to whatever medical condition they've been diagnosed with, okay? We're following so far? All right, awesome. So the reality is that we have to do more globally, but we got to start right here with our own. The numbers that I quoted you are from people right here in the United States that are dying every day from various cancers. Retinoblastoma, I'm sure if I put my team to research and start doing, I'm sure they'll find those disparities in this community as well. And so I am challenging you all to consider that in your various areas. Whether you're a nonprofit organization that hands out information about your resources, make them inclusive. If you are a medical professional that works in research and you have pamphlets and information that is whether it's digital or printed, make it inclusive. Make it inclusive for these community members. Inclusive Scan is not just about the deaf, the hearing impaired, or the visually impaired communities. It's also about our aging population. It's about those individuals who may have neurodiversities, such as ADHD or dyslexia, where they process information differently. The benefit of Inclusive Scan, it encompasses all of these communities. It has the ASL transliteration, but it also has the voiceover as well as plain language captioning on the videos. So again, it's not just focused on one community. It can be a benefit for all communities. Those persons who struggle with reading, this is a benefit for them. And if we really are committed to creating that awareness, then we cannot forget these marginalized communities that I'm speaking of today. Last couple things that I will say, in addition to considering making your literature inclusive of these communities, I would also tell you, when you get those clients or those patients that come to you who utilize American Sign Language, our office offers consulting services. Reach out to us, because we work primarily with ensuring that if someone is diagnosed with a life-threatening disease, they don't have the TV interpreter popping up. They don't have a different interpreter every day that can't follow their care. We place an interpreter who is qualified and certified as a medical interpreter to follow them throughout the duration of their treatment, which we know when you have a treatment team, it provides cohesion of care, right? So consider those aspects when you are working with these populations. And if there's anything that I can do personally or from our organization, reach out to us. We consult with everyone from the federal government down. So if you're familiar with Ability One, we consult with them on how to ensure employees have access to information and accessibility provided, as well as inclusive scan. We work with various healthcare systems currently in North Carolina, and we are spreading across the US and eventually global. So I charge you all with making the information about RB more accessible for these communities. Whether you need a video interpreted for you to post on social media, contact us. We have qualified medical interpreters to do that, to ensure that we're reaching a larger population here in the US, and again, eventually globally. Lastly, if there's anything that I can do to support you in that area, being that I have the expertise in inclusion and accessibility, let me know. I've shared my contact with most of you, but if you go on social media, you can find Inclusive Scan. I believe it's on IG. It's not a lot on there yet, because it's tough to find a social media manager that also understands accessibility, just being honest. But please feel free to follow that page or reach out to me directly if you have any questions on how your organization can become more inclusive of those communities. Thank you all for your time. Are there any questions, briefly, anything that I can answer for you? I know I said a lot. Most people don't understand enough about that community sometimes, but I can answer if you have anything. Nothing? All right. Thank you so much. Have a wonderful day. Oops, sorry.
Hello, good afternoon, and welcome everyone, including our online guests today. So we start with the Global RB panel. My name is Bhavna Chawla. I come from... So thank you, Marissa. I come from All India Institute of Medical Sciences, New Delhi. Delhi is more than 7,000 miles away from Hawaii, and I'm really glad and delighted to be here. Thank you for having me, Marissa, Jessie, Sandra, Maura, and One Retinoblastoma World team. And I'm joined today by our esteemed panelists. We have with us Dr. Damilola Bello. She is not here in person. Unfortunately, she couldn't join us. Damilola is the Membership Services Manager at the International Agency for the Prevention of Blindness in London, England. And she has a pre-recorded video which she has sent for us. I'm also joined today by Dr. Rachel Brennan. Rachel is the Director of Pediatric Oncology and Hematology at Logan Health Children's in Kalispell, Montana. She's also a contractor for St. Jude's Global Retinoblastoma Program. Then we also have with us today, where is Dr. Brenda? Dr. Brenda Gallie, she needs no introduction. She's joining us from Toronto, Canada, and she is within the retinoblastoma program at the Hospital for Sick Children. She's also VC Hope Canada's medical director and a member of the International Retinoblastoma Consortium. Dr. Maria Manquez Hatta, she is from Santiago, Chile. She's an ophthalmologist and ocular oncologist. She also serves as the chair of membership committee and secretary for Pan American Ocular Oncology at the International Society of Ocular Oncology. And Dr. Catherine Patton, welcome. Catherine is a clinical professor in the Department of Ophthalmology and Visual Sciences at the University of British Columbia in Vancouver, Canada. She is also the Ocular and Orbital Tumor Group Chair at BC Cancer. So we look forward to an exciting session with exciting talks. And the first talk is by Damilola Bello. So if we could have the pre-recorded video play for us, please.
Hello everyone, hello to One Retinoblastoma World. I'm Damilola Bello and I'm the Membership Services Manager at the International Agency for the Prevention of Blindness, also known as IAPB. A huge thank you to World Eye Cancer Hope for holding this program and for inviting IAPB to speak to you all. I'm going to be speaking a little bit about who we are, how we work, and zoning on one of our ways that we work, which is our campaign and our Love Your Eyes campaign. This first slide is inspired by the logo of the campaign. It is an enlarged version of the heart, which the campaign is all about. My second slide is titled The Global Voice of Eye Health. On this slide are a selection of our 250 plus members that make up the alliance from all corners of the world and all parts of the eye health sector. We have NGOs, professional bodies, universities, hospitals and research centers, as well as private sector organizations that make up this giant alliance and work across 100 countries. And in NGOs, we have organizations like Vision Spring, Sight Savers, Know the Glow, and most recently, World Eye Cancer Hope. Our aim is to work collectively with our members to end avoidable sight loss and make eye care affordable, accessible, and available to everyone, everywhere. We work with members across all different specialties, different sector formats towards a single mission because ultimately our voice is always stronger and louder together. The third slide is titled How IAPB Works and depicts a flowchart of our approach. So we and our network work across 4 key areas. The first is in influencing and shaping policy. Second is in campaigning for greater awareness. Both of these raise the profile of eye health and ensure the sector gets the political, health, and developmental priority it needs. The third way that we work is in data and knowledge, so we facilitate a culture of learning and collaboration. Lastly, listed is in connecting networks. So we bring members together at a global, regional, and national level to collaborate and build partnerships. So our approach is to utilize these areas of work to unlock political commitments and system changes to achieve the following. So, which includes things like eye care being integrated into mainstream health services, new investments unlocked, and improved operating systems and increased consumer demand. Ultimately, what this means is that millions more people will be able to see well and live well. Now, campaigning was the second way I mentioned that we work, and one of the ways this is through our biggest campaign, our Love Your Eyes campaign, which umbrellas World Sight Day. This fourth slide comes with the enlarged Love Your Eyes logo again. The campaign was launched following the UN resolution on eye health and quickly grew to a campaign that is able to call on the public, business, decision makers, and policy makers to make eye health a priority. This campaign is all about raising awareness and covers 4 main areas: prevention, understanding risk factors, symptoms, and healthy practices, empower people to prevent conditions before they threaten their sight; early detection, so awareness that teach people what to look out for and the importance of regular sight tests; overcoming stigma, and opening conversation so that people can seek support without feeling shame; And finally, empowerment, because informed individuals, informed decision makers, and informed politicians can take control of their own eye health and the eye health of others. So 2023's World Sight Day was by far our biggest and most successful yet. The theme was Love Your Eyes at Work, and members across the globe conducted screenings in different workplaces. We also smashed our Love Your Eyes screening pledge, which had a target of 10 million. And organizations and individuals pledged screenings and surgeries, helping us to reach over 13 million. This year's World Sight Day, which was just days ago, as you're watching this on October 10th, introduced a child-centered messaging. And as part of the child-centered campaign, we introduced a new variation of our logo, as well as the introduction of our new Love Your Eyes mascot. This evolution is illustrated on this slide, where the Love Your Eyes logo comes alive and turns into Artie. And Artie is the graphical representation of Love Your Eyes, of the Love Your Eyes heart, brought to life, a splashy, drippy paint, splattered version who's cheeky, joyful, and very creative. Like millions of children, Artie is short-sighted or myopic, and they need to wear glasses to see things in a distance clearly. Their glasses help them read the board at school. It helps recognize the faces of their peers on the playground and play games safely with their friends. And Artie has joined the global movement. This slide shows an Artie and Know the Glow collaborated design, where Artie is helping to raise awareness about leukocoria, Coats disease, retinoblastoma, and glow-related childhood blindness. And this is one of the illustrative ways that Artie can help raise awareness about important issues that is pertinent to you or most relevant to you. Different ways of talking to children. And for World Sight Day, we asked our members and wider network to pledge theirs or a child's eyes with a target of 1 million, calling for the screening of children's eyes. By the time of me recording this video, we are only 4,000 away from 1 million, and I'm very confident that we will exceed our 1 million target, considering the activities many of our members have planned. There's still ways to get involved, even as World Sight Day has already happened this year. You may have seen in a corner of One RV World poster about Glasses of the Future. So this year we are looking to get young people involved as well as carers and parents to ease children into getting involved in a Love Your Eyes campaign through a fun and engaging competition. So there are 2 categories with a chance to win a cash prize for their school or youth cup by designing a Glasses of the Future. So you can follow the QR code to find out more, or go to www.iapb.world/glasses of the future. And I've also left my email there, dbello@iapb.org. That's dbello@iapb.org. To find out more information, happy to answer any of your questions. And with that, thank you very much for your attention. And only by working together through collective action and intent can we tackle a challenge as large as sight loss around the world in our lifetimes. Thank you all.
Wearing heels today, but I feel like I'm just standing on the shoulders of giants as I'm in this room anyway. Hello, everyone. My name is Rachel Brennan. I am a pediatric oncologist currently in Montana, but previous to that worked at St. Jude with Dr. Matthew Wilson with the retinoblastoma program clinically. Since I've returned home to Montana, I cannot leave retinoblastoma behind. Rachel Brennan, my initials are RB. And so I will forever be linked to retinoblastoma in a different way, but I think just my passion for that will never leave me behind. So that's where I'm here today talking for the retinoblastoma St. Jude Global Program. So our first green button, yeah? There we go. So a bit of background, the St. Jude Global Retinoblastoma Program actually was formed in the year 2020, which I thought was going to be a great year to have program as based on vision and 2020 vision. And anyway, 2015 would have been better in hindsight, but isn't that how that always works? So it was made of St. Jude members and then also global retinoblastoma members. And we came together with the words of an African proverb that you can see here in this cartoon on the slide. The two teams giving each other a high five in the cartoon, and the words, if you want to go fast, go alone. If you want to go far, go together. And that's really what brought us all together. And with this in mind, that we have not only St. Jude global members, but we also have global RB members on this team. So our first group, I just want to introduce the Global Retinoblastoma Program. We have a St. Jude team with Dr. Wilson, who is actually one of our chairs. He's an ocular oncologist. Myself as a pediatric oncologist. Cassie Jo Groshek, who's a physician assistant for Dr. Wilson. Susan Ibarra, who is here with me today, who's our program coordinator and general herder of cats, as she keeps all of us together. Morgan Lockler and Bruisha Dahal are both postbacks that are a part of our program as well. And our little symbol you can see down there brings the surgery part, the medical oncology part, and then the nurse, but also sort of that global support that really is needed to come together to care for patients with retinoblastoma, with an eye in the middle that has a globe instead of a pupil as the center. But it's not just about St. Jude. So we have global members as well. And the triangle on this slide really shows you sort of how those tiers work. We have the St. Jude chair, Dr. Matthew Wilson, and the St. Jude Global Advisory Group chair is actually Dr. Guillermo Chantada. So he was here yesterday, but he has also he's just active in everything, and I think that really gets to the point of this community being so much together. We have a standing committee, the Retinoblastoma Standing Committee, that are elected from each region, up to 3 from each region. And then the advisory group, which has representation from 56 centers, 36 countries, and that's across 7 WHO regions and 5 continents. At the bottom of this, but not the least of this, is the Global Retinoblastoma Network. And that's all healthcare professionals, but really, I think, as we are hearing in this room today, it's really all of us gathered here that are affected by retinoblastoma. So we had 3 priority areas for the Retinoblastoma Global Program and identified those as needs assessment, that blue clipboard, early diagnosis, the orange one in the center, and then on the far side is the tumor boards with the group in green meeting around the table. That needs assessment is critical to understand current capacity in either an institution or in a region. And we started just with a simple survey in the Middle East to try and figure out how many oncologists do you have, how many ophthalmologists, what do you have available. But that's grown into a more formalized tool now that we call Profile, and have established actually a sibling tool of that, a smaller, a little bit more manageable survey type of a tool specific to retinoblastoma care and management. And we are just studying this first in a group of 9 centers across 4 regions, so we hope to have some of that pilot data in early November. That cartoon about the tumor boards and everybody meeting around the table, that's really multidisciplinary teams where you are assessing management, diagnosis, access, care, outcomes for all of your patients that are affected by retinoblastoma. And we have created a toolkit with our working group for tumor boards. And that toolkit can be used as a blank presentation to either help or augment an ongoing tumor board, or even to start a tumor board in a region that may not have had access to these MDTs before. And finally, the picture in the middle, that early diagnosis, really is how we need to work together to increase awareness and achieve that early diagnosis. And that's been a common theme you've heard here and will continue to hear. But I think components of the other 2 categories will still actually impact that. And so I'll draw from all of those areas as I continue with my talk. I don't need to say this out loud. We've seen the numbers. Early diagnosis will save lives. It will change. The high-income countries have higher survival with fewer patients who have extraocular disease, whereas the opposite is true in lower middle-income countries, where you have more patients with extraocular disease that really do impact that survival rate. So we need to address that, and that is one of those key time points that we can look at to say, are we shifting a needle or are we not? If we can decrease that median time of diagnosis, and if we can decrease the number of extraocular diseases at presentation, we are starting to move the needle. And the way that's being done, prior success around the globe, you know, when I first was thinking about this and was thinking about all of the published literature, right? And so there were lots of campaigns before 2010 and published in Honduras and Brazil and Mexico and India and Guatemala and Argentina. But really, we've heard about a whole lot more, I think, even since then. And those are not always a publishable, quote unquote, campaign, but each one is having an impact. So the key to all of this is if you look across the slide and you look across all of these different programs, the take-home point is one size does not fit all. And so when our early working diagnosis group came together with RB Global at St. Jude, we wanted to have representation from as many regions as possible, and we do have in our global panel for this working group, Mexico, Central and South America, Sub-Saharan Africa, Eastern Mediterranean, Indian, and Asia Pacific all represented. And you can see that in the map off to the side. And the idea was really to come together to understand what were the main points and the challenges. And our initial discussions, this group is very passionate. We have lots of discussions about what is the problem and what are the challenges, and we easily came up with the challenges list. I mean, that's the easy part, right? But how do we actually determine the best approach? And I think it comes back to the idea that this group, this working group is not supposed to create, enact, maintain, and run an early diagnosis campaign in every center across the world. That's not the point of it. Even if we were to depict one strategy to use, it doesn't work. One size does not fit all. And so we encountered or just put into groups these 5 sort of main challenges: education, regional capacity with workforce, personnel, equipment, referral networks or lack of referral networks, government policies and priorities, and then the need for collaboration, especially around funding and resources. And the charge of the group really has now changed to reflect that need to provide resources and a toolkit that can be adaptable by the personnel in each region or institution to create or pursue an early diagnosis campaign. And so how we're trying to address each of these is what I'm going to work on the next few slides. The first with education, we've seen a ton of the resources that are available. We do not need to recreate all of the educational resources. We need to adapt and then short and concise information, and we can adapt what is out there and use what is out there and put it across, in different areas. But there might be an infographic that might need to be more tailored towards a certain set of individuals if that's what the early diagnosis campaign wants to target. If that is, teachers, or if that is, faith workers or anything like that. I think we really need to understand what resource is going to be needed, but only the people and personnel in that region can really tell us that information. We also talked about email templates, presentation templates. If you're going to give a presentation to a government body, what type of information and how might you order that presentation to sort of get your message across in a clear and concise fashion that would really be important for your program going forward. And then guidance graphics for those who are running it, like what to expect, what happens when this happens, who do you contact, where are some other resources, so for the people who are running the campaign also to have some guidance. So education's important, but you also have capacity, because if you build an awareness campaign and all of a sudden flood a medical center with patients, but you're not ready to receive, to care for, to support these families and patients throughout their journey, it does everyone a disservice. And so capacity and understanding the capacity in each region is going to be a bit different. So this is that survey tool that we were talking about with the sibling, and it's got 10 puzzle pieces that all fit together, and they've got a cartoon graphic in each center of the puzzle piece, and then it also tells you the name for each one of those, because I'm not sure I would recognize the cartoon graphic for each one of them, but it's got a name as well. And the 10 of those: national context, facility and local context, personnel, service integration, chemotherapy, outcomes, back on the other side, patients, finances and resources, service capacity, diagnostics, and surgery. And so understanding how each one of these modules is a specific aspect of retinoblastoma management and patient care, and then putting all of that information together to identify the areas for improvement, but not just talk about them, to create an actionable strategy then to improve that piece of the puzzle overall so that your capacity is being built. And as I mentioned, we have our first pilot phase data as ongoing collection, and hopefully we'll move to the next set soon. So we'll have meaningful data in each area that will say, what is your actionable strategy to move on to the next piece? And really what the idea is then to build that level of networks based on the capacity that you find at each either local institution at the micro level, at the regional or national institutions, the meso level, or the macro level, sort of the overarching. And really would hope that if you can find a local institution able to treat, confirm disease, I think key, confirm disease, treat unilateral chemotherapy and nucleation and provide palliative care, then you move on to the next level to have additional layers of conservative therapy, focal therapy available, and then up to a global center of regional center of excellence to have all levels of care, and including some more of those things. I think, the argument that genetic testing should be available everywhere, sure, but you need some counseling to go along with that too. So I think sometimes those layers need to be just added on as you go through what that referral network looks like, so that if you're at a place where you need extra levels, you know where to go and you're not just left hanging. So while we address the adaptable resources that we can do within a region and understand that capacity building and network, we also need to address the governmental policies. I think lobbying, I heard, is definitely on that list as well, but we need to leverage the organizational pull. And I think in some ways, this is where that name St. Jude Global can help. And already St. Jude and the WHO have connected together and launched the WHO Global Initiative for Childhood Cancer in 2018. That's the GICC. And that initiative is bringing all these stakeholders together. As we've heard, retinal is one of those 6 index cancers to improve survival by the year 2030. And the pillars of the framework you can see here really are at that higher level, right? Care networks, universal health care coverage, regimens for management, those are the ARIA guidelines, evaluation, monitoring, advocacy, and then leveraged financing and linked governance. And one of the key, back again, that's what I wanted to do. Back. One of the key pieces of that, I think, is that global platform for access to childhood cancer medicines is one of the initiatives that they've done in the collaboration. That's the WHO, UNICEF, and the Pan Am Health Organization Strategic Fund. Look down so I say all these names right. The goal is to provide uninterrupted supply and access to chemotherapy. The chemotherapy that we heard is so critical and key into the management of patients with retinoblastoma. Again, you build it, they'll come, you have to be able to treat them, you have to be able to get the drugs that you need, but that can't be done on a regional level, that really needs to be done on a global scale. So we can leverage that type of partnership for those pieces. And then last is the collaborative efforts that really are ongoing, are a part of this room and a part of what we've talked about today. I mentioned the WHO, really to leverage that, you're thinking about correctable loss of vision, right? It's not just retinoblastoma, it's that awareness for every aspect of low vision that needs to be targeted. Know the Glow is not just the organization Know the Glow, but the idea of Know the Glow and all the social media and campaigns and everything that's encompassed in that slide, and how to really, I don't want to say harness the energy, but I want to say funnel. Funnel and connect and collaborate in a meaningful way, so that you're not just saying the same things over and over, but you're actually moving that initiative forward. The ISO Africa workshop that really got the ophthalmologists all thinking in the same room. We actually created like a little board game, almost like Candyland, but you can get from one side to the other. Where are the pitfalls? Where are the chutes and the ladders where you can connect, and where are we still missing? Where do we have to build capacity? And then it's the people here in this room today. And that is not just the healthcare providers and the social workers and everyone else. It's everyone who is here who has a voice and is using that voice, and I am so grateful, and I can tell you how grateful I am, but I'm going to let everybody else speak, because there is so much work that we can yet do, and this is not the end, but this is just the beginning. So thank you all.
Are there any questions for the speakers so far? Dr. Rachel is here, or maybe we can take the questions at the end. Yeah, so my presentation is on the burden of orbital and extraocular disease and how the global community can help. Next slide, please. So this is a picture of One World DC 2017. I think some of you were attending that meeting, yeah. And that was my first exposure to One World, and I was delighted to be there. I just loved it, and I couldn't wait to be at the next meeting. So thank you for having me here. So we've heard from the speakers over the last 2 days, and everybody believes that the goals of therapy as far as retinoblastoma is concerned is life salvage, eye salvage, and vision preservation in that order. So I come up from a part of the world where extraocular retinoblastoma is not all that uncommon. And this paper that we published a few years ago was a single center study at New Delhi, where of the 600 children of retinoblastoma that were diagnosed, more than 1/4 of them were extraocular at presentation. So we really have a high burden of extraocular disease in our clinical setting. And this is not just in India alone, but if you look at Asia, 43%, that carries 43% of the global burden of retinoblastoma, extraocular retinoblastoma is quite common. And again, the studies that have explored the global scenario of retinoblastoma, like the recent one we had, from the Global Retinoblastoma Study Group, talks about how prevalent extraocular retinoblastoma is in lower middle income countries. In this study itself, out of the 926 of the 4,000 plus patients that were recruited, more than 20% of them had extraocular retinoblastoma at presentation. And just as Rachel mentioned, it was the low-income countries that were presenting with much higher rates, almost 50% of extraocular retinoblastoma as compared to only 2% in the high-income countries. So clearly, there's a huge disparity in retinoblastoma presentation if you look at the world. And again, when it came to distant metastasis, we had a similar picture with the low-income countries showing a much higher rate of children having distant metastasis that was almost negligible in the high-income countries. And why are we concerned about extraocular retinoblastoma? We are because so much of research has shown that everybody knows that the survival in extraocular retinoblastoma is much less than when it is just confined to the globe. It's a major contributor to mortality, and once the child develops extraocular disease, he is more prone to develop metastasis and death. Now, we know that extraocular retinoblastoma is quite common in our setting, but what are we doing to tackle it? One, of course, is to increase the awareness and get them early. But still, there are many children who are coming to us at this late stage. So what are we doing as far as treatment is concerned? So we're using the multimodal approach to manage children with extraocular retinoblastoma. And this essentially consists of a combination of surgery, chemotherapy, radiation therapy, and that helps us in saving the lives of these children, although we cannot save the eye. So before treatment, some of the features that these children present with, some of you may not have seen what extraocular retinoblastoma looks like, but most of these children will present with proptosis. There can be pain, redness in the eye. There may be leukochoria. There might be, some of these terms may be technical, like a staphylomatous globe. Some of them have a fungating mass, and some of them even have an enlargement of the lymph nodes because the tumor has spread beyond the orbit to the local lymph nodes. So we do this imaging in these patients. We do MRI to confirm the diagnosis and to ascertain the local extent of the disease. It also helps us in ruling out pineloblastoma in cases of bilateral RB. Now, this is an example of an enucleated globe where an MRI was not done, and this you can see over here that there is extrascleral extension of the tumor that could not be ruled out at the time of diagnosis because the imaging that was to be done was not done. So, the pediatric oncologist plays a very important role when it comes to extraocular retinoblastoma because we as ophthalmologists do not manage these children. We send them to the pediatric oncologist and they do the metastatic workup, they see the extent of the disease, and then they decide how to treat it. So Dr. Chantida was here yesterday, and the International Retinoblastoma Staging System that has been proposed by him is the one that is most popular and universally followed in staging of patients with extraocular disease. Most of them are stage 2, 3, or 4, depending upon the extent of disease spread. So I just spoke about multimodal therapy. What does it mean? So it means that when we get a child with extraocular retinoblastoma, where there's orbital spread, obviously we're not thinking of saving the eye. We know the eye has already gone. We're thinking of saving the life of the child, and how do we achieve that? So we try to start with neoadjuvant chemotherapy, give the child 3 to 6 cycles of chemotherapy, and then when there is some degree of response, we repeat the MRI, and then we follow this up with surgery, which is enucleation, followed by radiation therapy, and the remaining cycles of chemotherapy. So this is one such example to show how well the tumor responded to neoadjuvant chemotherapy. There was a big orbital mass, and then it regressed. You can see the picture on the right. It really shrank well, and then this was a stage where it was amenable to surgery. We were able to do an enucleation and then follow it up with the remaining treatment. So this was where we evaluated 2 different chemotherapy protocols. What should be done for cases of extraocular retinoblastoma, which one works better in terms of efficacy and safety. And we came to the conclusion that it was the vincristine etoposide and carboplatin combination in higher doses that worked well in cases of extraocular retinoblastoma. Now, this is, I'm not sure how many of you have seen such advanced retinoblastoma, but yes, this is also a case of retinoblastoma. You can see that the tumor is not only into the orbit, but like I mentioned, it's also spread to the local lymph nodes, which you can see in the form of this massive swelling. And again, this child responded to this multimodal treatment protocol with neoadjuvant chemotherapy. It was followed by enucleation and radiation. And we can see that there's a significant reduction in the size of not only the orbital tumor, but also the cheek mass. Again, this was another child with more advanced retinoblastoma. You can see this was bilateral intraocular retinoblastoma, and then the child had an enucleation and then presented to us with a cheek swelling. And we were not sure what this cheek swelling is. It turned out to be stage 4A retinoblastoma, where the tumor had already spread into the bone, and a PET CT also revealed that it had affected the shaft of the femur, both sides, and the vertebra. So again, in this patient, we had the treatment of autologous stem cell transplantation along with the chemotherapy. And of course, all this part is taken care of by our pediatric oncology team. They do all these procedures. But in this particular case, the response to treatment was good, and the child is still surviving. Now, just a little bit mention about the COG ARET 0321 study, which was yesterday nicely described by Rachna. And here, in this study also, they have evaluated treatment options for extraocular retinoblastoma, the intensive multimodal therapy with different chemotherapy combinations. And this also seemed to work well with extraocular retinoblastoma stage 3. So here the survival, event-free survival at 1 year was 88%. For stage 2-3 disease, 82.6%. For stage 4A, which is the bone marrow metastasis, but it was not encouraging for patients where the tumor had already spread to the CNS. So as far as long-term outcomes of extraocular retinoblastoma is concerned, in our experience, they have been pretty good. The children that have been treated with multimodal treatment, they have had good long-term outcomes in terms of survival, and they are doing well even otherwise. We do have late effects of treatment like bony hypoplasia of orbit, because in these cases, children receive orbital radiation as part of the multimodal therapy. Secondary malignant neoplasms are always a concern, and so they're on lifelong surveillance and reviews. Prosthetic fitting is also a challenge, because once they get radiation to the orbit, there is contracted socket, and it's very difficult to fit a prosthesis into the eye that is aesthetically acceptable. And the challenges remain with CNS metastasis, which is stage 4B retinoblastoma, as we have seen with our experience with multimodal treatment, and also that has been observed by the ARET study. So as far as the barriers to treatment, you can understand these are socioeconomic factors, delayed presentation, which we've all been talking about for the last 3 years, and everybody's coming together to help us with that. There's lack of awareness, poverty, illiteracy. There are few tertiary care centers in a big country like India. There are hardly, very few centers that actually have the facilities to treat these kind of complicated and complex cases. And even to reach those centers is a challenge. There are long distances of travel, and then there are cultural factors, which we have seen from so many other presentations over the past 2 years. There's abandonment, lack of compliance. So these are all the barriers to treatment that we need to address to catch these children early and hopefully not have any child with extraocular retinoblastoma maybe 10 years from now. So I thank you all for your kind attention, and I acknowledge the contribution of my team that is working with me. And I invite you all to ISO 2024 Goa. On behalf of the ISO board, Jessie Berry is here. So we're really excited to have this meeting in Goa after 20 years. We had a wonderful ISO Africa meeting last year, and we look forward to seeing you in Goa. Thank you for your attention.
So I'll warn you, you're going to have some work to do. Please get your cell phones out handy. You'll all need your cell phones. So I'm going to talk about a new way, which you already had an introduction to yesterday, a new way to manage oncology data coming out of clinical trials. So what we did at Sick Kids 22 years ago, we built a database that had a timeline, like you saw yesterday, and the ability to draw on the computer. At that time, we drew on paper the diagrams of the retina and where the yellow was marking up where retinoblastoma tumor was active, but we also drew it in the database. We're still using that database every day at Sick Kids, but we're scared it's going to die any day because it's on such old Microsoft tools. So we have a new one coming. Then I mentioned yesterday the swimmer plot, which takes that same data of time, event, and type of event and dates, and turns it into a different view that lets you compare patients and pull different patients together instead of just looking at one patient, which is what we've been doing at Sick Kids. The database eCancer Care, the top one, only exists in Sick Kids and can't be shared with the world. And then I introduced the consequence score. We're going to come back to that, and then leading into propensity. So why is there no slide there? Okay, don't worry about it. This is a swimmer plot, and it shows multiple different patients and all the symbols of all the different treatment types there. And you see the important one for the yellow triangle for enucleation. That all shows comparing each of these separate patients for all their time courses, so you can begin to compare them for studying. And you view all of the patients with interest together. This gives us symbols, and we define in this a complete response, and this is also a new idea, I think, in oncology. Please, oncologists, tell me that's not true. That the definition of complete response is that the treating team, which at Sick Kids is a whole lot of people, consult virtually now, and we all agree that tumor doesn't need any more treatment. As soon as a treatment's done, then it changes the whole scene. And we recently had that on one of our patients quite late, 2 years after the chemoplaque, had a spot that was hot, and that was lasered, and that makes a deviation. He's no longer a complete response by that simple definition. So the consequence score is an idea we had to get more value out of those points. Right now, a laser would be exactly the same as a nucleation, just looking at the timelines, but we wanted to quantitate what is the lifetime impact of each kind of treatment. And so these are the measures, the categories that might influence you to say that one was worse than the other. Some physical harms, functional loss, like loss of vision or anything. Emotional, psychological harm. We've heard lots this week about different aspects. Effects on quality of life. All sorts of things have had great discussion this week. Long-term impact on education, on careers, long-term impact on job opportunities, and health risks, i.e. inducing second cancers at a higher rate, for example, by external beam radiation or organ damage. So this is the consequence scores that we made up out of the top of our head. You can see all of them have a value, with the highest values of 30 being external beam radiation or removal of the last eye. And at the top, I can't see that very well. I should be looking over there, but I can't see that one either. EUA is examination under anesthetic, which wasn't in our list, so I just have question marks because I don't know what value we would put for harm on a consequence for EUAs, but I'll ask you for your opinions. So one thing you can do with this number, the quantitation, and this shows that if you add up all the events that happened to these children before they had the intervention, which in this case is the chemoplaque, and then after, and you can see that you can actually put a quantitation on the impact of treatments based on their overall perceived harms that might arise from those, not whether they worked or not. So now I'm going to stop talking, and I'm going to pass over to Kristen Small, who's going to take over the Menti, and now you need your phones handy.
Hello, everyone. This is Kristen Small. Apologies, you won't be able to see me on camera. I'm speaking from the AV booth. We're going to try something a little different. We're going to run a Menti survey. So for all of you viewing remotely, or for those of you in the room, please take out your cell phone, or you can open up another browser on your internet, and we are going to go through the instructions of how to sign on to Menti twice. So bear with me this first time. What you're going to do is not scan that QR code, because that is just a sample. We'll show the official one in a second here. The QR code can be scanned, and that will take you from your cell phone directly into the Menti, or you can open up the menti.com website, and then it will have you enter the code in just a minute to get to the survey.
They're changing computers now to the Menti computer.
All right, so this is the QR code that you can scan. It's coming up here in just a second. Sorry, guys. Okay, so that's the QR code to scan. So if you scan the code on the right, you don't need to do anything else. If you decide to go to a menti.com web browser, then you're going to enter in the code when prompted. We'll leave this up for just a moment to give everyone a chance to get signed in. For those of you in the room, if you could raise your hand so we can see you and you got signed in, that would be super helpful. All right, and then you should all be seeing waiting for presenter, and then we're going to go to the first question right now. This question is, where are we now? You're simply going to touch on the map in the vicinity of where you think we are. I know it's a little small. Do the best you can. Oh, sorry, guys. Internet's slow. A little worried about the.
Has it worked for anyone?
Still need the code. It's showing at the top of the screen right now, 34998980 or 8908.
Sciences.
Apologies, guys. 1 second. We're going to.
Sorry?
Yeah, I think we're just going to have to do it together. Sorry, Brenda.
Okay.
Internet's not cooperating with us
Should we
today.
give up?
Yeah.
Okay. Oh, you went to the, can you go to the next question?
Yeah.
Oh, yeah. Go to the next question quickly.
You got it. Before it quits on us.
It's just the internet's too slow, is that right?
We're seeing now in real time as people are responding, which is fantastic. We're also seeing people joining the survey, which is great. So thankful it started working. Yep, I still see people answering the question. Excellent. We're going to go on to the next question now. This question, you're going to see sliders under each of those. You're going to simply move it to the right. If you keep it all the way to the left, that's 0. If you move it all the way to the right, that's the most severe, which is 30. And they're somewhere in between if that's how you would evaluate it. One, two, a couple people have responded. The survey will be updating in real time, so what you're seeing on screen is the aggregate of everybody voting. Or responding, I should say. Give everybody 1 more minute.
Sorry, some people are asking what is tylectomy? Tylectomy is when you do essentially a vitrectomy, but you take out active tumor from inside the eye surgically. And that actually is quite safe to do the way it was designed and built by my colleagues in China.
All right, we seem to have stopped at 33, so we're going to go to the next question. It's same thing. You're going to move those sliders over, depending on how you would evaluate severity. right, 30 more seconds. I think that's everybody. So we've got one more question, I believe. Yes, this is an open form field. You can text your answer to this question. The question is, how would you define the consequence of a treatment? Like you have quite a few responses here.
I think that's fantastic. You've worked very hard. Thank you very much. We'll go back to my slides, but I won't take long. I'll just skip through them quickly because we've taken a lot of time with this, but this is hugely important how you've all participated here. So I just wanted to show briefly, and it'll be very brief now, how we have used the swimmer plot idea and the consequence scores, and you saw some of those results for the chemoplaque. But I also want to introduce Kelvin, who is the really genius who's making all this work, and how he takes retrospective data out of our old 22 years of data on all the children seen with retinoblastoma inside sick kids, and turns that into a set of controls for, in one case, the chemoplaque, but for any different intervention, the same model would work. So the first step he used is the consequence score to say, how do you match the patient who had no chemoplaque retrospectively, and the interval we use is the same time window, so the same treatments are available as the chemoplaque patients might have had before they got their chemoplaque. And how do you match that? So the top one in blue there is a patient who had a chemoplaque, and so the chemoplaque's the green line, and it's very clear that it is it's time zeros when that went in. But we have to find the time zero from controls. So we take controls that had also a total consequence score, counting 3 for each of the intraarterials, and then the fourth one turns it to 12, and then we find similar matches, and you can see they're quite a good match here between the two, and then we designate time zero as the time just before the next treatment, whatever that would have been for that child. And then, if that's a perfect match, that's fine, 1-to-1. We want one control for each patient or participant in the study. And then we have, we match by, if there's 3 potential matches, to the patient at the top in blue. Then we would look at the pattern, and you can see that the top one there had 3 intraarterials and more lasers, whereas the others all had 4 intraarterials, so that the bottom ones in green are the ones selected, but then we still have 2, so then we did a full internet randomization to see which one do we use and put into the study for the propensity. So this is just a collective answer of all this. All the gray lines are propensity matched by those criteria to the blue ones, which are the study intervention. And that would be a way to go forward with retrospective controls. And in fact, the chemoblack went to an FDA committee, and we had prepared a randomized study, but they didn't want to see the randomized because they said with the retrospective controls, we don't need randomization. That would be immoral. So that's pretty exciting to have the potential that this matching could replace and let drugs, anything you're studying, move forward quickly. So this is the other thing we haven't talked very much about, but I think Caitlin's talking later about Depict Health, which is the database on the Azure cloud to be able to be seen and used anywhere in the world, whereas eCancer Care is just inside sick kids. This is the same model, same kind of timeline, and the timelines I showed yesterday are out of Depict Health. And that then is offered through the charity that manages Depict Health to any site, retinoblastoma treatment site in the world whose institution signs a collaborative agreement to allow their retinoblastoma team to use eCancer Care as a communication tool in patient care and patient health. And of course, the Depict Health is viewed not just by the clinicians, but by the patients in real time. They can't change the data in it, but they can view it as it's happening. And then a second consent is asked from each participant, each patient, who have to be consented to be in this at all. If they don't consent to have their data in Depict Health, then they stay in their institution's record. And the real ownership of the record remains the institution. This just has summary data that's needed to draw pictures and have timelines. And then coded and aggregate data can go forward and be used first to give back to each site, because one patient might be in more than one site. In fact, many of them are treated because they move around or because we refer them around to wherever the best care is. And that site gets back their data, so we're not stealing their data. In fact, we deliver it back to them in a really nice research-ready format that they could do whatever they want with. And then coded data would also go into longitudinal data for Research Ethics Board approval, and that might include in the future the example of swimmer plots, consequence scores, and propensity match tools might be attached to that data at some point. So that's just looking forward for a new way to get clinical data from each site specific to that site or from the whole world in an ongoing way. So we're not sitting here wondering where is the longitudinal data we didn't get around to collecting as it was happening. This would solve that problem. Thank you. Thanks for your participation.
Good afternoon, ladies and gentlemen. Thank you very much for staying here until this afternoon session. My name is Maria Manquez Hata. I am ocular oncologist from Chile. So this is my financial disclosure, and as we already know, there is a different situation regarding the high-income countries and low-income countries. In the high-income countries, diagnosis is at an earlier stage, mostly intraocular, at 14-month-old. In low-income countries, diagnosis at a later stage, mostly extraocular extension with a high rate of mortality. So based on this World Bank map, Latin America is in the light green, and that means upper middle income countries. The exception is Chile, Guyana, Uruguay, and Panama. Those are dark green countries. My country is the southest point of the world, at the bottom of the planet, and we are 20 million people. The capital is 7 million, and we have 2 centers for retinoblastoma patients, one in the private system and the other in the public system. Dr. Lopez and Dr. Osandon, they are pediatric ophthalmologists. They were very well trained with Dr. Brenda Gallie in Canada, and they are in charge of those patients. Dr. Lopez present his experience with retinoblastoma during the last 10 years in the last national meeting, and he mentioned that we have nearly 15 new cases every year. And most of them, 70% of them, are treated in the public system, meaning that part of the government public health care. And they are mostly intraocular. However, the stage of diagnosis is at very advanced stage of intraocular disease. 65% of them are stage D or E, meaning that there is a very, very large tumor. Survival rate is 98%, and we have chances to have intravenous chemotherapy, intraarterial chemotherapy, plaque radiation, cryotherapy, and everything. So we have chances to use all the tools for conservative treatment. No matter what, we still have 53% of enucleation. What is the reality in Latin America? For Mexico, Brazil, Colombia, Argentina, and Chile, those countries, they have a very well-trained ophthalmologist and pediatric oncologist taking care of patients with retinoblastoma. And all those countries, they have the tools for providing conservative treatment. However, the main barrier is the late diagnosis. When you have advanced stage, intraocular advanced stage of disease, you require a long and intensive treatment with side effects without any warranty of avoiding enucleation. That is the point. No matter how good doctors and good treatment you have, there is no warranty. And you have collateral side effects. So in terms of diagnosis, Chile is in the middle of the high-income countries and low-income countries. For unilateral disease, diagnosis is at almost 2 years old. That is very late. For bilateral disease, it's at 9 months old. Latin America, sometimes you can have a diagnosis at the 3 years old. For the patients living in Brazil, in the Amazonas jungle, diagnosis could be at 4 years old. In Chile, we have a law that is the HES. It's a government health program and set up pediatric cancer, no matter what kind of cancer, could be leukemia, retinoblastoma, is a priority. It's a priority in terms of the referral and the treatment, and that is valid for public and private system. Once you detect leukocoria, there is an obligation by law to refer the patient to one of those specific centers to be treated. And it works very well. The problem that we have late detection. That is the barrier. So what is my role there? As an ophthalmologist, I was trained by Dr. Carol Shields and Jerry Shields at Wills Eye Hospital as a clinical fellow during 2003 to 2005 at Wills Eye Hospital, Philadelphia, and then I came back to my country. But what I found as the doctor, we receive very, very severe cases. As you can see here, both are bilateral stage D and stage E. So it was a very hard situation for us, for me, as a young doctor, to challenge how to treat those patients, trying to preserve the life, the eye globes, and the vision. And I had the intuition, with no scientific evidence, that the red reflex was not done at the well-child care visit. Also, I had the feeling that the sensitivity of this test was not as good as we thought, mostly because the test is done by non-ophthalmologists. It's pediatric healthcare personnel. In Latin America, the child well care visit is done by the nurses, not by medical doctors. And in my mind, the problem was not the retinoblastoma, the problem was the late detection. So could parents help on this? Not so much, because as you know, the digital cameras and mobile, they already block the red reflex. And where you can see the leukocoria on the pictures just when the tumor is extremely big, even though you cannot see it on the regular mobile. So in 2013, I stopped seeing new patients, new RB patients. We already have very good colleagues who were taking care of them. And I went focused into the MDI Care, an app. We developed a photographic camera app with, we unlock the mobile camera, allowing to show the red reflex without eye drops. And we present our experience in the International Society of Ocular Oncology meeting in Cleveland 2013 here in United States. And with the prototype, we were able to show the red reflex in patients. This is a real picture. And also, we took a picture with a regular camera of the mobile, and you cannot see the red reflex. And that was the result of our prototype in 2013. Over the years, the iPhones changed with different softwares and hardwares, and the app worked randomly on different models. So there was a need to perform more R&D, and it was not as simple as to develop an app and uploading into the App Store. Over the years, Dr. Aparna, who is a pediatric ophthalmologist, she presented her experience in the American Academy of Ophthalmology with our app, and she said, yes, she's right. We were able to detect leukocoria not only for retinoblastoma, but also for cataract, for Coats disease, and even for high refractive errors. Over the years, a group from India tested our app in their retinoblastoma clinic with 24 patients, and they were able to detect leukocoria with our app in 80% of cases. Small tumor were detected in 50% of them, medium-sized tumor were detected in 83%, and large tumor were detected in 100%. And that was with our prototype. That one was a proof of concept. Later, Dr. Juan Pablo Lopez published this paper, and this was a survey presented. It was an anonymous survey presented to the healthcare personnel in Chile. And the question was, do you perform red reflex? And the answer was, yes, sometimes, 30% of cases. Most of them, they did not do the red reflex. Why? Because they did not have the direct ophthalmoscope, or even they ignore how to use it. The question is, would you use an app? And 80% of doctors, they say, yes, we will use. During pandemic, a group of pediatric ophthalmologists performed this review, performed this strategy, and they recommend the patients in Trento, in Italy, to use our app at home to test the red reflex with the children. And this is the paper, this is the review, and that was published during the pandemic. And this was interesting meta-analysis, and it was published a couple of years ago, revealing that the accuracy of the red reflex performed by the pediatric healthcare personnel done with the direct ophthalmoscope really had a very low sensitivity, 17%. Why? Because when you get closer into the eye with the light, you are getting a smaller pupil. Why? Because you activate the light reflex and the nearness reflex. So it's not easy to see the red reflex with the direct ophthalmoscope by a non-ophthalmologist personnel. That is the challenge. So what we are, and which point we are now, we developed an upgraded version of MDI Care. It's a new version that is supported by artificial intelligence, that we capture the images at the time that the pupil is large, before getting smaller, and we upload into the AI. And it has higher sensitivity, it takes 30 seconds per child, requires little collaboration from the baby, from the parents. It has low cost, portable, and provide an images. And what we have now is, this is the report. We capture the images, upload the images, AI, the artificial intelligence, provide the results that is normal or not normal in terms of the red reflex. and we are detecting leukocoria from retinoblastoma, cataract, or even high refractive errors. Our model is to provide the service to the institution, and the institution can have a main account, and the personnel, for instance, nurses, pediatrician, or other technician can have access to the software, and they can test the child when they are seen at the well child care visit or even in the vaccination. We have been supported by grants from Chile and United States through the Child Blindness Prevention Program grant. We are in the beta testing system. We are not in the App Store yet or in the Google Play yet because we are just testing the sensitivity. And today we're preparing a pilot program with the government at a large scale. We have IRB, we are working in the IRB. We have the support from the National Cancer Agency, and we are working with the Ministry of Health. This is all my teams. As you can see, it's a large number of colleagues, ophthalmologists, lawyers. we have supported by 2 international buffet of lawyers. We appreciate we were selected by the Mass Challenge Accelerator company in Boston. They are helping us in terms to provide a service as a social impact company or service. So thank you very much. We want to create a brighter future with a life-saving photo.
Good afternoon, everyone. I realize I'm standing between you and a coffee break and discussion break, and I applaud all of you for still being here. I wanted to thank the organizers so much for an absolutely fabulous conference that has made linkages and is clearly going to move retinoblastoma and its care and the people who have thrived with it forward. I got asked to give a talk, I think at a time when maybe the rest of the program wasn't filled in yet. And so you will see slides that were on my slide set that you have seen already. So you already know the information. And I also submitted it the month ahead, which meant I went by the requirements. There are no really pretty slides in here. And I both apologize for that and applaud that because it made me be prepared ahead of time, and it also made me really cognizant of what happens with slides that have so much on them that they can't be seen or described. Welcome to the audience who are with us online. My name's Catherine Payton. I work in Vancouver. My only conflict of interest is that I really care about retinoblastoma, but I have no financial or academic conflicts to declare. I have a great debt of gratitude to the people who taught me, Brenda, Gallie, Lynn Murphy, Francis Meunier, and many, many, many others, and to the patients and families I have served. The One World group has this map up on its website. I'm at the far left end of Canada, just above the American border, not very far away from Andrew Stacey, whose work I'm going to be quoting from. And you can see here how filled in this map is and how global our concerns are. Now, the question that I was asked was, is the incidence increasing? I will come back to that later. Much like Guillermo Chantada, I'm going to say I can't answer your question exactly, but I will give you some information. The annual case estimates, in my slide, I have left Africa off here because I think we are just getting a good handle on this. But in Canada, we are about 1/10 the size of the US, and what we quote to each other, but isn't what's in the Canadian data, is about 25 new cases a year. America is 10 times that. China is 1,000, and India is 2,000. And then you heard our colleagues talking about Oceania yesterday and Australia, and the big group just in South America and in Africa. is the incidence actually increasing? Well, why would you want to ask that? What about the incidence matters? And I think it depends on who's asking and what you are actually trying to assess for. And that's why I'm going to go into the details of what's actually being asked and where the data or lack of data or skewing of data is coming from. It matters for function. It matters for who are we trying to look after, what are we trying to do. It matters for survival worldwide, and then it matters for what kind of healthcare planning do we need to do in advance. For everybody at this meeting, it's only about retinoblastoma, but we need to think about how that stacks up against other diseases, both in society and in the call on medical and support services. It allows us to have comparisons. If we don't know how many there are, then we don't know if we're getting better or worse, and we can't predict so well. It allows us to analyze why differences might exist between outcomes in one place and another. It helps us direct our research, both the bench-type scientific research and the psychosocial research. It provides data, as I said, for resource planning. So why is it so hard to answer what sounds like a simple, straightforward question that your 3-year-old should be able to count them up and tell us what's going on? It actually matters what you count, how you count it, and who you are counting. So it gets easy to say, how many cases are there per year of retinoblastoma? But that might not actually be the question you want to ask. Australia and Canada have a relatively similar disease burden. And when I went to look at the Canadian data, it looks like a great big sawtooth, up and down and up and down. And where I am in British Columbia, I may have 1 case this year and 6 cases last year. I didn't have an epidemic. I just had averaging. So another way to look at that data is actually to look at what's called a case cohort. That work has been done by Tero Kivela and some folks in Northern Europe. And what they said was that we want to look at the group by age by which one might anticipate retinoblastoma had happened. The majority happened by age 5. If you start going a little higher than that, there's always 1 or 2 late presenters, but if you take the cohort that goes to age 15, you may be less accurate. So calling it an age cohort instead of an incidence per year may help you to count better. So when you're looking at the data, you want to look for that. When are you going to count them? Well, you could count them at birth, which is what happened, or you could count them once they've got their disease, which is what this 5-year group does. Now, that also depends who's doing the counting. And so many of the European countries, we heard, have a national registry or database. They have one center providing care, and they know where all the cases are. In Canada, it's required to report all malignant disease, so one would think that our Canadian national database ought to include all of this. I will come back to that later. You could also be counting in a center, but your cases may come from somewhere else. And then one of the confounders that I have found is later on in life, when you're trying to help plan for future care, you may have in-migration or out-migration. So you're looking after the offspring of retinoblastoma people, but they weren't originally cared for by you, so it looks like all of a sudden your population has gone out. And then who does the counting? Are they doing it for actuarial reasons, or is it the health system that's doing it? I have always enjoyed this quote. I don't mind numbers, I'm not math adverse, but Mark Twain is often quoted as saying that figures beguile him, and he quoted Disraeli, a Brit, who said there were 3 kinds of lies: fibs, damned lies, and statistics. And I bring this to you to say that the statistics aren't really lying to you, it just depends if you know how they got there. So I want to step a huge amount back and talk about all ocular cancers. And thank you to the people who are translating and confirming the slides, because this one and actually the one after it upset somebody. In the UK, ocular cancers, I'm talking about all ocular, not retinoblastoma, are not in the 20 commonest cancers. In the US, ocular cancers are not in the top cancers. There are 3,320 per year. It comes between the incidence of joint and bone cancers and penis cancer. Yes, that was the correct word. The global analysis of cancer registries says it's 0.15 to 0.2% of all cancers. And this is ocular cancer. So you can see we're a small percentage of cancer. And if you go to a system that is focused on numbers and that wants to improve the most number for the investment, then they want to know about breast and lung and prostate. And that's not what this group is interested in, nor should you be, but you should know what you're up against. So this is the American Cancer Society 2024 estimates, and you can see what the numbers are there. So I thought I would go and look at the childhood cancer one. And in Canada, retinoblastoma comes close to the bottom, but not right at the bottom, right between carcinomas and melanomas in children and hepatic tumors. I was having a conversation with the oncologist from Sick Kids, and Furkan gave us lovely slides to think about this morning, and we agreed that rare tumors are rare, but when you put them together, they're a large group. And so retinoblastoma needs to position itself in pediatric cancers, but still within the rare cancer group. And if you approach it as a rare cancer, you're a large percentage of what's out there. You've also seen this. Somebody else presented yesterday, but I thought it was interesting for this group when you start talking about numbers. So it mattered to the WHO's group to look at retinoblastoma as one of 6 diseases in childhood cancer. And they were trying to look either for things that were addressing common challenges or connecting to vital partners. And their emphasis was on early diagnosis, just what we've been talking about here. But that means that until the 2030 deadline, it's a focus. So within the rare childhood cancers, it is a focus, and we need to somehow take advantage of that. I want to talk about a registry, though, because they were talking about registries. And I'm going to read to you, because I thought this captured it well. Patient registries have grown in size and number along with general computing power and digitization of the healthcare world. We all think a registry or a database is a good thing to maintain, but it actually has a definition. In contrast to databases, registries are typically patient data systematically created and collected for an express purpose of answering health-related questions. So that's what makes it a registry. Registries can be disease, procedure, pathology, or product-based in nature. Registry-based studies typically fit into level 2 or level 3 in the hierarchy of evidence-based medicine. For the non-medical people, that is how they evaluate whether or not the studies are good. A recent use in registry data has been development and execution of registry-based trials, which may elevate registry-based studies into the realm of level 1 evidence. So the registries, that retinoblastoma registry worldwide, is helping us to gather material. Some strengths of registries include the sheer volume of data. A rare cancer, when you collect more of it, at least we've got more numbers. The ability to be linked to other registries and databases. Limitations of registries include variable quality of the collected data and a lack of active follow-up, which could underestimate rates. As with any study, the intended design does not automatically lead to it being of a certain quality. And while no specific tool exists currently for addressing the quality of registry-based studies. Some important considerations are coming forward, and perhaps that's on the near horizon. So I think if you think about collecting data, the idea that a tumor registry is important is why the global registry has gone forward, why that map matters, and why trying to collect what we can matters. Now, they also need to be maintained. They may come from multiple sources, and you have to know that you're not double counting data. The database is just electronic collected material, and so it needs to be more than a database, because the database doesn't actually answer a question. So coming back to, is the incidence of retinoblastoma increasing? One would think that you could go and look at one of these registries and say yes or no. This has been a question of interest for a really long time, and we've got intermittent articles that go back for about 50 years, so I'm only going to address more recent things. An article in Sweden and Finland that looked at 40 years worth of disease in 2004 said it was stable. The American Surveillance for Epidemiology and End Result, or SEER, is a big kind of data collection, but not always complete. A study of that done in 2004 said retinoblastoma incidence was stable. A 2019 article about Canadian data written in 2019, but looking at a decade-old data, said it was stable, which all sounds fine, except the people who wrote the article aren't involved in retinoblastoma care. And it said there were 18 a year, and we don't actually think there are 18. Those of us who look after it have been saying for 10 years that there's more than that. So I have to take that one with a grain of salt. The folks in Finland went back and reanalyzed later. They have a single base for their country, and they've got good data, and they're using the concepts of this cohort. And they looked at their data and said, yes, the incidence is increasing, and it's amongst familial retinoblastoma, suggesting that it was survivors of retinoblastoma and thrivers of retinoblastoma who said, yes, we're having family, this is part of normal, we understand what care requires, we're still willing to do this. So that was their data. In 2021, Andrew Stacy, who you met, and Dido Fabian, who was on the Zoom, and a group looked at European data. And the European data generally looked pretty good, except when I look at what they were able to collect, they identified Germany as not having adequate data to be able to be included in the analysis. And personal communication from Andrew was there was one center that wasn't willing to put in data. Only one center, but then that meant they couldn't use any of the rest of it. The same was true for Italy, that they were close, but they weren't complete. But he said even in those groups, they were finding the same thing. In my studying days, we used to say there was 1 in 18,000 was the rate for retinoblastoma, 1 in 18,000 live births. And we have talked more recently about 1 in 15,000. This 2021 article is pinpointing 1 in 14,000 with an increased rate, but again with the same result that it is familial retinoblastoma. So that talks about stable populations, but what's actually going on that we care about is there's more retinoblastoma. There's more retinoblastoma being detected and treated in Africa with good outcomes because we've got better care. And so one could expect more identification. We heard about Oceania, and we heard data that made retinoblastoma a really common pediatric tumor. And discussion with Dr. Sullivan says that that's because they're not even getting to identify those with other malignant diseases, and those childhood cancers, the patients are dying and they're not even being counted in the childhood cancer data. So although there's data there that suggests it's common, it's probably no more common than it is anywhere else because we know genetically the kind of things that lead to it are still all stable. there is a lovely article that I thought was going to give me the answer, and it's entitled Disease Burden, Risk Factors, and Temporal Trends of Eye Cancer, a Global Analysis of Cancer Registries. Hurrah, somebody's done it. And they have a lovely whole paragraph about retinoblastoma in the front of the article. And they have no further reference in their analysis later on. They talk about survival in global cancers. They talk about the incidence of viral infections and of ultraviolet exposure. That's not retinoblastoma. So I can't look at anything else that's in that and come up with an answer. And then there's what you see on the World Eye Cancer Hope website, which is saying, no, it's not really increased, the numbers are explained. Nonetheless, I think what we're looking at here is that there's an increased number and an increased visibility of retinoblastoma. There's an increased effort right now. We will be seeing children who survive retinoblastoma from many parts of the world where that may not have been so previously. And our numbers on that map that I showed you may be increasing still. I would like to say mahalo to everybody for your attention and acknowledge the people here. For those on the line, I have a photograph. The one on the left side has Brenda Gallie hiding in the dark again, talking about One RB World at a Canadian retina meeting, just in case you think we only talk about this stuff when we're together. The middle one is Andrew Stacey and Didi Fabian, who have worked through the Tropical Medicine Division of the London School of Economics, I believe it is, and have been really interested in databases and what we can learn from that. And the photograph on the lower right is a group of us who were together at the World Ophthalmology Congress in Vancouver in August and presented multiple aspects of retinoblastoma, amongst other things. And then the final slide is a picture of the wonderful folks that I work with and have the privilege of taking care of at a national meeting. We were a remote wired-in site of a Canadian meeting, Australia, Africa. I would encourage you to know that this business of connecting with each other electronically is kind of the way everybody has to do things. And it was really energizing to have everyone together in the same room. So I hope I've given you a little bit of something to think about, that there are, statistics are not always exactly what they seem. You need to know where they've come from, and that the things that are causing retinoblastoma are still the same. The genetics are becoming more and more clear. We may even be using them for long-term survival and thriving. And I really look forward to what somebody will say about this, 25 years from now. Thank you so much for your attention.
Thank you very much. So that brings us to the end of this panel, and I'm really grateful to all the panelists for the excellent talks that we had this afternoon. We can now go on to the next session. Thank you.